Welcome to Inside the Studio, the official podcast of the Texas Heart Institute at Baylor College of Medicine. I'm Dr. Joseph Rogers, and together we'll explore the ever-evolving world of cardiovascular care. In each episode, we bring you conversations with the people shaping the future of heart and vascular health, cardiologists on the front lines of patient care, surgeons performing groundbreaking procedures, and scientists leading discoveries that will change medicine for generations. We'll also highlight perspectives from international leaders and community voices who share our commitment to preventing, diagnosing, and treating heart disease. Whether you're a physician, a researcher, a patient, or simply curious about the latest in heart health, this podcast is your inside look at innovation, education, and care at the highest level. So let's step inside the studio.
Welcome to another episode of
Inside the Studio,
our podcast here at the Texas Heart Institute. Today I have Dr. Brett Doliner, Dr. Ramsey Kalil. They're fellows, cardiology fellows at the Texas Heart Institute, and we're going to talk about hypertrophic cardiomyopathy. We recently wrote a paper about a review paper on the Texas Heart Institute Journal. By the way, you're more than welcome to submit your papers to the THI Journal. And we think it's an interesting and important topic. We see a lot of patients with HCM here at THI. We have a few talking points to cover. And first I want to get you guys started. What is HCM? What is hypertrophic cardiomyopathy? And why is it important? Ramsey, what do you think?
Sure. Thank you for the opportunity to, speak about this topic. In general terms, HCM or hypertrophic cardiomyopathy is essentially thickening and enlargement of the heart muscle. At some point, that can lead to obstruction of blood flow out of the heart, at which point it's referred to as hypertrophic obstructive cardiomyopathy, or HOCM. As you may hear, it's a leading cause of sudden cardiac death in young patients. It's something that is being more and more recognized and is a fairly common entity that by all means at some point you'll encounter someone that with it. And so it's an increasingly important thing to understand, how to screen for it, how to diagnose it, what it means in the context of having it, and how you can operate on your daily life, how to operate, when you do or do not have symptoms, and how to approach, screening people that are close to you. So I think it's a very timely topic in the context of, the current era of cardiology, and it's important for people to understand it.
And how common do you think it is? And do you think it may be underdiagnosed, underrecognized, or?
I think historically it probably has been underdiagnosed because the majority of patients with it don't have symptoms. And so, clinical studies from the past had cited somewhere around 1 in 500 patients, or 0.2% of the population may be diagnosed with it. But that being said, there are kind of newer trials and, retrospective reviews that cite maybe an incidence as high as 0.5%, or 1 in every 200, based on the prevalence of certain genes that have been associated with the disease. But not all of these cases are associated with patients that having symptoms. And so the variability in who has symptoms, who doesn't, who goes to the doctor and finds out they have it through testing can be a challenge in diagnosing patients. But 1 in every 2 to 500 is probably the estimate that we can comfortably tell patients then.
Yeah, what I'll add to that is that, HCM has commonly been understood to be a genetic disorder involving genes that sort of code for proteins in the heart muscle. And, with current genetic testing, not everyone that has what we would consider to be clinical hypertrophic cardiomyopathy, which we largely diagnose based off of imaging studies and symptoms, not all of them will test positive for a gene associated with the disease, but it is largely considered to be a genetic disorder involving a gene mutation.
I think you're probably right. I mean, when we make these prevalence estimates, we use mostly symptomatic disease or small studies, right? And I think a lot of these patients with sort of mild HCM that doesn't really phenotypically manifest may not be caught. Maybe they're attributed to hypertension. They never have any problems. They don't get assigned to the HCM. So yeah, it might be underdiagnosed. But even if it's not, it's still quite common, 1 in 500 people. This is a loaded and difficult question, okay? It sounds simple, but it is not. Actually, a lot of people have done research in this subject locally. Dr. Paolo Angelini, rest in peace, worked a lot on this, and is a very controversial point of discussion that doesn't only apply to HCM. So, Brett, if I do heavy exercise, should I be screened for hypertrophic cardiomyopathy?
Yeah, that's a great question. I think that part of the increase in prevalence that we've seen with HCM has partly been attributed to certain countries starting programs where they screen athletes for HCM. And so the most basic screening test is just a 12-lead EKG, where you can see some signs of HCM in individuals, because we particularly want to know about HCM in the athletic population. We know that it's a condition where during periods of intense aerobic activity, usually, that those patients with HCM can be at a higher risk of sudden cardiac death. So certain countries, Italy being one of the most notable ones, had started, a screening program where all athletes get screened with the 12-lead EKG. And that hasn't been widely adopted among, all countries across the world, but some countries have started to do that. So moving from, sort of the screening process to, now I've been diagnosed with HCM, can I engage in heavy exercise? And I think, like Dr. Postalian noted, it's a loaded question and there's not a clear answer. I think that our previous stance on this was that heavy exercise should be avoided. Light activities, walking, going up flights of stairs was generally considered to be okay. But again, because there's this risk of sudden cardiac death with periods of intense activity, doctors generally counseled their patients to avoid it. I think that more recent studies have argued that maybe our exercise restrictions are a little bit too far, and that maybe we should be lightening exercise restrictions so people can live sort of a more, fully engaged life, being able to do all the activity that they want. But it's still a pretty heavily debated topic. I think that as of now, it's sort of an individual decision. Patients should talk about with their physician, what type of activity they can engage in. And it depends on patient-specific factors, how bad their HCM is and whether or not they already have a cardiac defibrillator in place.
And just to add to that a little bit, in terms of who should get screened, anyone who is having symptoms that are kind of atypical during exertion, things like chest pain, or fainting or near fainting, or shortness of breath out of proportion to the fitness level of an individual, should at least prompt consideration of screening. Anyone who has a family member or a first degree relative who's been diagnosed with HCM should be considered to be screened. And those, who are at extremely kind of elite levels of athletes or highly competitive sports that require short, intense bursts of energy, basketball, sprinting, football, etc., should, be at least considered for screening due to the prevalence of the disease, particularly in those populations who are at highest risk for manifesting symptoms and ultimately dangerous complications.
I think a lot of the professional sports teams do this. Okay, part of it is because they're investing significant amount of capital in each individual, and they want to make sure that they're healthy. But the controversial question is in high school age kids that do really competitive athletics. Of course, you see in the news an athlete died in the middle of exercise. It's obviously a very strong emotional response is elicited by that, and it's reasonable. Now, the question is, if you start screening a lot of these kids, you might start finding small abnormalities on the EKG, on an MRI, on an echo that would potentially disqualify them from sports when that shouldn't have happened. So it's a difficult question, but I agree. There's no doubt that someone with symptoms of shortness of breath, chest pain, especially with activity, should get an imaging study of some kind. Someone that is a first-line relative of someone with hypertrophic cardiomyopathy definitely should get screened. And then competitive athletics, I don't think that question is fully answered yet. And the guidelines are wishy-washy on how much exercise you can do for that specific reason, because not every patient is the same.
Yeah.
The phenotypical expression could be worse in one individual compared to another. You could have a lot of nasal state VT. Someone could have no VT. Depends on the gradient of obstruction of the LVOT. I think that it is true that we were a little bit too restrictive originally, but I'm a little bit cautious of the message now seems to be always less and less restriction. Now I don't want to go too far the other way. It's a tough conversation to have with each patient. What I tell them is, don't do anything that brings you to a level of exhaustion that you cannot say a sentence. If you're doing exercise and you're that's probably not a good idea. I think they get
No,
when I
that's
do
a fair
that.
point. I mean,
I don't know how many meds that is, but
with the advent and evolution of the armamentarium of how we can treat patients with HCM, how it's evolved over the last 50 years or so, I think that has empowered us to loosen some of the restrictions. But I agree that we shouldn't swing too far, past right, just because of the dangers of the risks in that scenario definitely outweigh the benefits of liberalizing someone's exercise regimen a little bit more than maybe we should.
yeah, dying is not a good
High
thing.
risk, yeah.
It's a pretty high risk. Okay, so a way in which these patients go on to have sudden cardiac death is through arrhythmia. All right, so once we identify a risk of that, we can implant a defibrillator, which is under the skin, shocks the heart if they go into a bad rhythm. Who gets a defibrillator and why? And I'm going to go with Brett because he is going to be an electrophysiologist soon.
Yeah, it's a great question. What I'll say is for defibrillators, just from a historical perspective, I think the one intervention that really has increased longevity for HCM patients is the defibrillator. If you look at outcomes data, years ago, we're talking 40, 50 years ago, before defibrillators were widely adopted, patients didn't live as long, and now they're living much longer. That said, defibrillators don't address any of the sort of clinical symptoms or quality of life decrements that come with HCM, but they do provide longevity, and it's probably the single most important intervention for that. Who gets a defibrillator? It's a great question. There are very clear guidelines on this. Although there are some patients that don't quite fit as nicely into any specific criteria. But the main ones that we look for are, if anyone has a clear history of a sustained ventricular arrhythmia or a dangerous rhythm, they get an ICD.
How much VT?
So typically, I'll pass this back to you because I think you probably know.
No. I don't think we know. So
Yeah.
The reason I'm saying is one of the criteria is non-sustained VT on a monitor is one of the soft ones like the LG 15%.
Yeah.
How much? I don't think that's specified. You get these patients and you see frequent PVCs. You get runs of 6, runs of 10. It's hard to sometimes ascertain who actually would benefit. But
yeah, that's
sorry,
right. I would say that the standard criteria for sustained VT would be 30 seconds of the arrhythmia. For episodes less than that, if you don't fit into the other buckets that clearly qualify you for an ICD, it is ultimately up to the clinician and the patient in a sort of risk-benefit discussion. But having some type of VT, because often non-sustained events are a predictor of future sustained events, is certainly one of them. People who have had a history of syncope, so you've passed out without a clear cause. Sometimes we can tell from a history that someone had, a vasovagal event that's clearly not arrhythmogenic. But if you've had syncope that's not explained by other things, and you have HCM, that generally buys you an ICD. We also look at certain imaging criteria. So if someone's thickness of their ventricle or their lower chamber is really thick, more than 3 centimeters, that we know that those patients are at higher risk, as well as on cardiac MRI, we look for something called late gadolinium enhancement, which is essentially a surrogate of scar tissue in the ventricle, which is ultimately the substrate for these bad rhythms. So there is very clear criteria on who benefits from a defibrillator. I think, as Dr. Postalian was noting, there's still patients who don't fit nicely into any criteria, but you may still be worried that they're at risk for sudden cardiac death. And we have risk scores that are available online that sort of help us give some type of estimate, but it's ultimately comes down to sort of the art of medicine and talking with patients, trying to give them the best estimate you can of what risk they might be, and sort of the downsides of having a defibrillator, of which there are a few, in coming to some type of shared decision making.
Great answer. I love it. Ramsey, Give us an overview of the treatments. What are the treatment options in medical, minimal invasive, or surgical for HCM?
Sure. Before getting into medical therapy, some of the, everyone, with every disease, lifestyle modification to that term is thrown around as a way to, prevent it or treat it or address it. So just to briefly address those, if you've been diagnosed with HCM, how should you modify your activity? Like we sort of alluded to before, you should obviously avoid strenuous enough exercise that's causing you to be so short of breath you can't complete a sentence. But also avoiding things like overheating, dehydration, and excess use of diuretics or medications called vasodilators are in that class, because all of that can potentially worsen the obstruction, worsen symptoms, increase the likelihood of dangerous heart rhythms that can potentially be fatal. So all of that should be considered as first line intervention. Beyond that, the classic category of medications that we use are negative inotropes, which essentially decrease the contractility and the oxygen utilization by the heart. Those can include things like beta blockers, calcium channel blockers, disopyramid, where they've been used for many, many years. The experience with them has been very good, and they are considered still to this day the first line medications. There are newer classes of medications called the cardiac myosin inhibitors, which have been shown in multiple clinical trials, Valor HCM and Explore HCM, to kind of improve clinical outcomes and functional status and symptoms in patients with hypertrophic cardiomyopathy, and they are fairly well tolerated. Since their advent over the last few years, kind of insurance coverage and access to these medications has definitely improved, which we've seen in our ability to actually prescribe these patients and prescribe these medicines to patients and actually get them to follow through.
Last time I checked was like $90K a year for mavacamten. But again, I'm not. This is not a diss against it, because I think it's a great medicine and I use it. I've used it quite a few times, but. This is just an example of how
a barrier
how
to
things
access. No, it's a fair point.
Can affect adherence, but
and beyond medical treatment, lifestyle modifications, that will address the large portion of patients that you encounter, but there are still a significant subset of those patients who either don't tolerate medicine, don't have access to medicine, or despite the maximal use of medicine and lifestyle changes, are still having symptoms, still have a gradient, a pressure gradient inside their ventricle that's leading to symptoms. And those patients are the ones that we should consider, quote unquote, more invasive therapies, which can be divided into, the surgical myomectomy, where we're taking having a surgeon do a procedure where they're taking a piece of muscle, or progressively more pieces of muscle based on how someone responds in the operating room, to decrease the ability of the heart to lead to obstruction, or doing a less invasive procedure where in the cardiac catheterization lab we use alcohol targeted at specific blood vessels that supply the region of this thickened muscle to almost like a controlled fire, to kind of put that out in that area and decrease the size of it over time. And our experience with that has been increasing over the last couple of decades. And original studies sort of demonstrated that maybe surgery was still better when the techniques were a little bit newer for the catheter-based approaches. And again, like you sort of alluded to, a lot of the experience with this and the knowledge of it and the comparisons were with these smaller scale studies. And so, patient selection, improvement in both access to equipment and comfortability with the procedures is sort of, leading both to be viable options in a lot of patients. And we have experience here at the Institute where we've treated several patients that are either highly, preferring a non-surgical option or deemed to not be surgical candidates based on their comorbid risk conditions. And so it provides patients with another viable option for treatment moving forward.
I think you're right. I mean, obviously, just to make it clear, if someone is young, low comorbidities, surgery is the better option, right? But I don't think alcohol septal ablation is necessarily a bad option for some of the other patients.
Yeah.
When you compare patients and you say, well, alcohol septal ablation has a greater complications rate than myectomy or mortality in the long run, a lot of that is because patients were older, sicker, et cetera. So I think it's still a viable option, like you said.
Agreed.
I want to, and that's what we published, by the way, Patient Degrade. give you a little bit of a curveball. I want to get the perspective of a future interventionalist and a future electrophysiologist who will implant ICDs. If the risk of sudden death is greater during intense physical activity, then one would gather that it has something to do with oxygen consumption, ischemia, obstruction, something mechanical and electrical, but as a consequence of high adrenergic drive, but also mechanical obstruction, perhaps. If someone has a good septal myectomy, very good, and the patient had a syncopal event that was unexplained and a family member that had sudden cardiac death that was not operated on, if they have no residual gradient, no symptoms, do they still need an ICD?
That's
give me the EP opinion first, and the interventionalist.
Yeah, that's a great question. I think we ultimately have to come back to what are the reasons that these patients develop these dangerous ventricular arrhythmias, and I think it's multi-component. I think that probably in the beginning stages of the disease, it is probably something that's more mechanical, meaning that a patient has high exertional activity, their heart starts squeezing harder, and at the same time, the more it squeezes, actually the less blood flow the heart's getting. And so we talk about this supply demand. Exercise increases the demand, and it also reduces the supply in this population of patients. And so I think in that case, it probably is mostly a mechanical thing. I think that as the disease progresses and you have more remodeling of the heart, that you get deposition of scar tissue, which in of itself can probably be sort of arrhythmogenic, which may be sort of exacerbated by exercise when we have these sort of, what we call catecholamines circulating. But it's not entirely just mechanical. And so for that specific patient that you brought up, if you've relieved obstruction, I would probably look towards some other diagnostic studies before making that decision. On outpatient monitoring, are they having non-sustained episodes of tachyarrhythmia, particularly during exercise? You could also do some type of stress test at a sort of moderate intensity and see if they have arrhythmia burden, and then also see if they have scar tissue on MRI. I think that, again, knowing the disease, I would sort of favor ICD if they met some type of criteria for it. But in a patient who really wanted to avoid it, I would sort of want to make sure that there wasn't any signs that they would be at risk based on other non-invasive studies.
I think I largely agree. If you theoretically correct the underlying problem that's leading to obstruction, you hopefully will, abate the ultimate cause and progression of symptoms down the line.
You're obviously not fixing the cellular disarray, but you're reducing some of the strain.
The hypertrophy and the strain, moving forward, and the obstruction that's been happening that ultimately led to the diagnosis and treatment with the myomectomy. I, again, agree that the substrate for the dysrhythmias is still probably there. So in most patients, it's still probably appropriate to implant. But I also think it's reasonable before you go ahead and commit them to that to have a discussion and potentially do provocative testing like stress testing, or have them wear a prolonged Holter and prove or disprove whether there actually is any arrhythmia that provides a solid reason for you to be able to, implant an ICD. And if it's sort of in that gray zone you sort of asked about before, well, what if they have very short runs of NSVT? What if they're asymptomatic? What if it's not actually as severe as these classic teachings or a 30-second run of sustained VT? Then I think it's, I would continue to monitor those patients and, at regular intervals, either screen them or have them come in sooner for follow-up if they're having any symptoms that are either new or recurrent.
This question has been interesting to me because obviously you don't want a patient to have sudden death. Implanting a defibrillator is a relatively low-risk procedure, but it's not risk-free, right? It's in the long run.
Yeah.
This doubt arose from a conversation that I had with a senior surgeon, old school, and in my mind, it was kind of like what you guys are saying. Like, the defibrillator is still useful, but in his mind, and then on another surgeon's mind for the same era, it was like, what are you talking about? The obstruction is gone. You don't need a defibrillator. Like, flat out. So I investigated this, and sudden cardiac death rates drop significantly after a successful myectomy. But there are still appropriate STD shocks in those patients, and at a much smaller number than the not operated patients. So yeah, I think we still don't know how to separate both groups, but I guess it's an individualized decision because we
So would you, put a Holter or stress the
exactly
patient
what you
or
guys said,
anything?
get an MRI, see how much scar you have. What was the reason to put the defibrillator in the first place? If it was a family member that had sudden death, but you have a smaller ventricle and you have no obstruction anymore, then maybe that's lower risk if you have no ectopy. It depends, unfortunately. That question.
So I wanted to bring one question back to you, Dr. Postalian. We were talking earlier. It made me think that, we were discussing sort of the screening of the athletic population, and you brought up this sort of cascade of testing. I think one thing that we see clinically is patients will get referred for having high voltages or EKG abnormalities who are athletes. And then, they have sort of thick hearts, which can be a sign of sort of just an athlete heart. And so when you're seeing a patient in clinic who, has an abnormal EKG or they have a thick heart on echo, maybe they have some type of nonspecific symptoms, how do you go about trying to distinguish whether a patient has an athlete's heart or they have clinical hypertrophic cardiomyopathy?
Yeah, I mean, that's a good question. And in some cases, it's really hard to tell, and it causes a lot of anxiety in families, especially if you involve parents of younger kids that are doing athletic activities. Athlete's heart, essentially the cavities enlarge along with the heart thickness. There's also enlargement of the RV, and there should not be scarring on MRI. They should also not be having a lot of electrical ectopy and SVT, etc. So that's what I use to differentiate that. There's a lot of specific measurements. If the LV thickness is more than 1.5, 1.2, 1.7, depending on the age, then increases likelihood of HCM versus not. But those are the general principles. We have really easy access to MRI, which makes it a little bit simpler. If you just have echo, smaller centers, that can be a little bit more challenging to ascertain. So what I would say is if someone encounters a difficult patient that falls within the borderline, you're not sure, then just refer them to an HCM center, and they'll probably be able to sort it out.
Yeah.
Okay, so you talked about myosin inhibitors. They're good medicines, okay? They directly inhibit one protein that contracts muscle, decreases oxygen consumption, improves symptoms. Why are they not first line?
I think initial.
Why don't we do the beta blocker dance?
I think that they're much more accessible medications. The
beta blockers.
The beta blockers, accessible, affordable, easily titrated. We have decades and decades of experience with them, and patients have easy access to them. I think the question will become a little bit more challenging to answer in the next set of years, hopefully as the cost of the myosin inhibitors decreases, and patients are able to afford and obtain them more, and we actually have better long-term data to demonstrate how well they tolerate it, how much they need to be titrated, and how significantly gradients drop over a longer period of time, while patients are on them.
I know that I'm being sort of like leading into an answer, but I mean, I actually think that right now we don't have enough evidence to say it can be used first line. And beta blockers may have other positive effects, like reducing arrhythmias. I mean,
sure.
It's hard to know for sure.
Yeah.
But that's being studied. Myosin inhibitors alone, first line, what are the outcomes, how many events, et cetera, et cetera. So we'll have the answer, but I really hope that accessibility and pricing comes down. You guys are fellows. You might have dealt with it in clinic with a few patients, but one of the limitations is that these drugs are new. So there's concern. There's a lot of eyes on this. So there's a portal that you have to take some training, log all the patients that you see, input all these data. There are algorithms that you have to get an echo now, then 4 weeks later, then 4 weeks later, then 12 weeks later, then 12 weeks, and depending if the EF drops a little bit, then you de-escalate the dose, you escalate the dose, and some of those algorithms a few of those steps don't make much sense. And I think most doctors recognize that, including the company, but that's the way it was done in the trial. So there's a lot of hoopla around using them. So I think as cost goes down, limitations go down, and data increases, then those drugs will be much more common.
Yeah, I think it really is challenging, the sort of hurdles that you mentioned that go into prescribing these drugs, even though they have pretty good data. Because now you're looking at you take something like beta blockers or calcium channel blockers that most, physicians, cardiologists, primary care doctors have some comfort in managing. Now you're taking a drug class that you need specified training in as a cardiologist, and need to know all the drug interactions and what to do with the medication around the time of surgery, all of which is specialized knowledge that you're sort of reserving this for, people at specialized centers. So I think that's, one of another challenge of these drugs is that we need a way to make it more accessible, not only to patients, but also to the prescribers who are going to be giving them out.
Indeed. Well, do you guys have any other comments you want to make? Any thoughts? No?
I think that one point that we had touched on before is the role of genetic testing for families and whatnot, and getting a diagnosis of HCM, for an individual potentially implicates other members of the family. So I think it's important for those other members to get screened, and depending on the results, to potentially extend the genetic testing, to further and further tiers. Sort of the idea of cascade genetic testing, taking the patient 0 or the proband and then screening their first degree relatives, depending on the positivity, screening theirs, primarily because it's an autosomal dominant disease. You have a 50% chance of passing it down, and so it can focus resources for the patients who are, for the patient's family members who do test positive, so that they're appropriately screened with things like ECGs and echoes, at appropriate intervals. And it, can also quell the fears of, siblings and other first degree relatives, and, who test negative, not having to worry about, reproductive counseling and genetic implications for future generations. So I think it is, given that the screening is accessible and affordable, and, for now low cost and easy enough to get, I think it's worth it in those populations, and people should take advantage of, places like HCM centers and other kind of providers that are able to offer these services to them.
I mean, you explained it very nicely. I mean, if you are someone that is concerned about possibly having HCM, but you have no family members with it, it's not like you should go and get genetic testing. That's not how it works. So you get the family member that has the disease, they get the genetic testing, and then you check for that gene in the family members. Now, if you were diagnosed with HCM based on clear imaging, then it makes sense to do genetic testing on you, even if you have no family members that have the disease.
I think, there's somewhat of a misconception out there among the general public with genetic testing that, you get a test done and you get an answer, yes or no, that I have the gene. And like many things in medicine, it's more complex than that. I mean, sometimes we find that someone has a variant in a gene that we can say with, near 100% certainty that they, will have or will develop symptoms of a disorder. But oftentimes in genetic testing, we find variants, so variations of the gene, where we think that there's a possibility it could be linked to the disease, but we don't know with certainty. And so, as Dr. Postalian was mentioning, genetic testing is complex. Sometimes it can lead to sort of situations that cause more confusion than they do answers. And so we're very careful with who we screen for the genetic disease. And we're also very particular in what order we do it, meaning screening the one that the family member that has it and then cascading to additional individuals.
Yes, some genes that might be flagged as abnormal, VUS, may mean nothing. And then you might have no abnormal genes identified, and you still have the disease because it's one that wasn't tested for. We haven't identified yet.
Yeah.
So it's complicated, and that's why these direct-to-consumer genetic tests are difficult to interpret, essentially. I think this was a really good discussion. I want to say if someone with HCM is watching this, know that There are treatments available, many different types, and the life expectancy of the disease, if detected early and managed appropriately, is essentially a normal life expectancy. So that's really exciting, and for that now we can pretty confidently say that. And thank you guys for coming, for discussing the subject, and thank you for contributing to the literature with your experience on treating patients with HCM, especially because you did it with the THI journal. So
thanks so much for having us. This was a lot of fun.
Yeah, agreed. Thank you very much. Look forward to the next one.